Well, kia ora koutou katoa, no mai haere mai. Thank you for coming to today's update. I've got Brigadier Jim Bliss with me again today, and I'll hand over to him after I've made some opening comments. First, I'd like to just give an update on the new positive case of COVID-19 that we announced last night, sent out a media release about, before giving you our daily update on cases in managed isolation. So this latest case, we're calling case C, is a close contact by virtue of being a co-worker to our case B at the Grand Millennium. That's the case B is the person who we spoke about last Thursday, who tested positive last week. This latest case and their partner are now at the Auckland quarantine facility, and the partner returned a negative test yesterday. Once again, just to confirm that this latest case had already been identified as a close contact, was in isolation, initial test was negative, and it's the subsequent day 5 test that has returned positive. So the person has been in isolation during their infectious period. Our whole genome sequencing results have now been completed on case C as well. This has shown that this case is very closely linked to cases A and B, case A being the cleaner, who was announced on the 22nd of March. This is what we expected. It shows there is a clear epidemiological link between these 3 people. And we now have a clear timeline starting with the returnee who arrived back in New Zealand on the 13th of March and the cleaner at the Grand Millennium who tested positive. The positive test was recorded later on March the 21st and announced on the 22nd. And having looked at the detailed results of those genome sequences, I can say that the genome sequence for the returnee, case A and case B, are identical, which suggests very direct transmission. In our latest case, case C, there is just one, what we call base different, and that fits with the pattern of being infected by case B. They worked at the same time. He was a known close contact. We don't have the direct epidemiological connection between cases A and B yet. They both worked at the Grand Millennium, we know, and we're just looking at their shift patterns to see if there was a crossover there to find that connection and to find out if there could be any intermediary between case A and B, given the time period. I think that the identical genome sequences suggest or reduce the likelihood there is an intermediary there. Vaccination status. I know there will be interest in this. Both cases B and C haven't yet had their vaccinations. However, there is no suggestion that they are vaccine hesitant or don't want to be vaccinated. I do want to note that vaccination status, like all personal health information, is private to individuals. We do not routinely release it as a matter of course. However, in this instance, we have let both individuals know so they are aware the information is going to be released. Understand that case C has been wanting to be vaccinated, but there may have been complicated recently by being in isolation as a close contact of case B. The testing history of case B is also being further investigated. What we do know is that since the middle of March, which is our period of interest, that case B hadn't had a test until this one last week, which showed the positive result. So the period of interest for all these cases has been extended back further out of abundance of caution as a result of getting more information from case B over the weekend and from subsequent verification of that through looking at bank records and phone data and so on. And we have done repeat PCR testing and serology and whole genome sequencing, and the serology in particular suggested that the infection may have been ongoing for a few days. So that's why we've taken the period of interest back, and some locations of interest go right back to the 29th of March. And just to clarify, all those locations of interest that we released yesterday relate to case B. There are no locations of interest for case C because that person was already isolating. However, keep an eye on our website for updates, and if there are any others, we will be updating that. Our contact tracing team reports that 10 out of 11 close plus contacts of case B have now returned negative results. The 11th is the additional case, case C, who returned the positive result yesterday. Of the other close and casual contacts, there are a total of, actually let me just go through, 5 out of 8 close contacts have returned negative results. The remaining 3 are still awaiting their test, so they're having it on day 5. and there are there are a total of 9 what we call casual plus contacts. 7 have returned a negative test and the other 2 aren't due yet. So total close and close plus and casual contacts, we've had so far just the 1 additional case, and that was the work colleague. And remember, our cases we test on days 5 and day 12 after exposure. I want to just encourage people to continue using the Tracer app. It's an incredibly important tool in our efforts against COVID-19. In the last 24 hours, there were about 650,000 scans. That's down on the previous 24-hour period, so just encourage people to keep using the app. There is some new functionality on it, and your app should have updated, and please do turn on Bluetooth. Just an update on the vaccine rollout. We remain confident in the progress of the vaccine rollout, and over 110,000 doses have now been administered around the country. We'll have a fuller update on Wednesday. We're continuing to work with individual DHBs around vaccine supply, demand projections, and the workforce they need to anticipate the vaccine that they might require, and to make sure they have that in place in accordance with their plans. The overarching focus remains on delivering as per our vaccination rollout plan and ensuring that we get early access to those most at risk from or most likely to be exposed to COVID-19. Having moved through most of the border and MIQ workforce and quite a number of their household contacts, we are now well into vaccinating the approximately 480,000 people in Group 2. We are working with DHBs to finalise their individual plans that go through to the end of June, and those will be made available in the middle of the week publicly. We have no hint that there is any problem with vaccine supply. Pfizer continues to notify us ahead of time of vaccine deliveries, and they have met every delivery date and quantity so far. That's very encouraging. And as I say, there'll be an update on Wednesday further on the vaccination work. And just because of our locations of interest, there are additional pop-up vaccination centres, including one at the Mount Roskill War Memorial from 10 a.m. tomorrow, and that will be operating all week. And please check the Auckland Regional Public Health website for where you can be tested. Now an update on other COVID cases today. Aside from the case we reported yesterday, there are no other community cases to report. There are 7 new positive cases in managed isolation. 3 of those were contacts of existing cases. And the 7-day rolling average of new cases at the border is now 9. There's 1 new historical case to report, and we've had 17 recovered cases. So our total number of active cases today is exactly 100. And that brings our total number of confirmed cases to 2,227. I'll leave it at that, and I'll hand over to Brigadier Bliss.
Thank you, Dr. Bloomfield. Kia ora, everybody. The health and safety of all of our returnees and the staff and the wider community remains my top priority and utmost in our focus. Following the notification of the positive staff tests at the Grand Millennium, a number of steps have been taken. As a result of the identification of Case B, an out-of-cycle infection prevention and control audit was conducted on the Grand Millennium, similar to previously been conducted at the Pullman and the Grand Mercure. This is a standard process in this situation in order to continually review our processes, our policies, to ensure they remain fit for purpose and appropriate. No significant findings have come from this audit that were giving us any cause for concern. Tomorrow, the Technical Advisory Group will meet and make any recommendations about the operation of the facility outside of this audit. The Auckland Regional Public Health Service is undertaking an investigation to identify the close and casual contacts, as already briefed by Dr. Bloomfield, also amongst the staff, and we're providing advice to anyone that has been affected. Last Wednesday, I put a hold on additional returnees entering the facility for a week in order to allow the staff to not only support the current operations in the facility, but also to facilitate this investigation. We've also brought in additional staff capacity to deal with the investigation. I'll just say at this stage, the Pullman the Grand Millennium is our largest facility, so we are managing a large operation with a diverse workforce, as well as conducting the investigation. We're working with health officials on what happened in this case to see what further improvements can be made to strengthen those processes. And returnees will continue to receive regular health checks, scheduled COVID-19 tests, and are being asked to continue to comply with infection prevention and control protocols, and they are at this stage. Grand Millennium is the largest facility, as I said, and has served us extremely well over the past year. There are currently 347 returnees in the facility, and thousands have moved through this facility and back into our community safely. Grand Millennium has about 170 staff and 445 rooms, so as you can see, a large population. Dr. Bloomfield mentioned about the testing before, and I can confirm that from the period 22 to 8 April, those that worked in that period, 98% of those staff have been tested, with a further 2%, or the remaining 2%, to be conducted this week. Last week, we marked the 1-year anniversary of MOQ, and over the last 12 months, we've seen major changes, and we'll continue to see changes as we learn from our experiences and adapt to new discoveries about the virus. We have been at the forefront of keeping COVID-19 out of New Zealand, and our workers have made considerable personal sacrifices to keep our communities safe. Thanks to their efforts, we've seen over 130,000 people through MOQ, and I think I'll take the opportunity to personally thank each and every one of those workers for what they do. We are now focusing on establishing the cause of infection for our staff. We do want to highlight, and we know that the focus and attention will be on individuals, but we must also protect their privacy and support them as MIQ workers. Thank you. We're happy to take any questions.
Dr. Bloomfield, why are there people working at the front line who haven't been vaccinated?
There are people at the front line. There are many people at the front line who have been vaccinated. There are others in the process of being vaccinated, and there are others who are still to be vaccinated.
Why
and from this week, because it's a large workforce, and everyone we know has been invited. Some haven't yet taken up that invitation. It was always envisaged there would be a period that they would be given to take up the invitation. As the Prime Minister said last week, and again, this was clear from the start, if people were unable to or unwilling to take up the offer, then other arrangements would need to be put in place, and that process is now underway.
Both of you, though, have taken the opportunity to talk about the front line being our first defence against COVID-19. These guys are going out there on behalf of New Zealand, and yet there's still chunks that haven't been vaccinated against this virus. Is that acceptable to you?
Well, there will be a range of reasons why people haven't been vaccinated.
So you're not surprised by this?
In fact, I'm not surprised in the sense that we always anticipated there would be some who would be very keen right at the start, and we saw our workers right from the first day, many of them willingly coming forward. There would be others who would want questions answered and who might look to see what their colleagues were doing. And there would, at the end of the day, be some who would be unwilling to be vaccinated. This is not because there hasn't been the opportunities for people to be vaccinated and both the offers made and appointments made for people, but there will be a range of reasons, a whole lot of reasons why people may not have yet taken up the offer. Now they have until the end of April to be vaccinated, and in the meantime, all the other measures remain in place, including regular testing.
Dr. Bloomfield, you said that Case C was keen to be vaccinated, happy to be vaccinated. Why hasn't that opportunity been offered to them?
In fact, my understanding is that the opportunity has been offered, but the opportunity was unable to be taken up, and there will be a whole lot of reasons that could be behind that, but they will be personal reasons, and the offer remains there, and it will be facilitated as soon as possible.
Over 3 months, how has there not been an opportunity for them to have had at least one vaccination?
So we started vaccinating on the 20th of February. So we're under 2 months so far. It's about just over 6 weeks, 6 to 7 weeks. The opportunities have been afforded, and we have seen very high uptake by this workforce, particularly amongst some of the workforces, some of the employers there. Others, and this employer told us last week around 80% of their workforce had been vaccinated. Now we are working hard to make sure the remaining ones are also vaccinated, or they are moved into other roles.
On the vaccination of the border workforce, do you know how many border workers haven't yet been vaccinated?
I don't have the exact numbers yet, and there's a reason for that, and Jim may want to comment in due course, but our border workforce is changing all the time, because we're recalling there are over 300 employers actually in the border workforce around MIQ, airports, and our ports around the country. There are staff being rotated in and out from a range of employers. So as it were, the denominator does change. So it's very difficult then to pin down exactly how many people haven't been vaccinated. Our aim is to make sure everybody is vaccinated. If they are not, then other arrangements need to be made to move them out to the front line.
Is that concerning for you that you don't know how many people on the front line have or haven't been vaccinated?
We know how many have been vaccinated, and the challenge is the denominator does shift around, and so at any point in time it will change. However, so I'm not concerned about it. What I am concerned about is making sure that we have all our frontline workforce vaccinated. And if they can't or won't be, then they need to be moved into other roles.
And actually, Brigadier, did you want to speak to...
On the 80% figure, what happens with the other 20%? Are they still at work, or have you given them an immediate stand down until they get the vaccine?
As the Prime Minister said last week, everything needs to be worked out by the end of April. So starting from this week, there are conversations with individuals who haven't yet been vaccinated. My expectation is that most of those people will be vaccinated. We've seen very high uptake in some of the workforce groups, and my expectation is, and we will make every effort to make sure it is easy for people to be vaccinated before the end of April. Otherwise, they will be having a conversation with their employer about other roles.
That's still a number of weeks away. Is it good enough that it's going to take till the end of April? A lot of people will be looking at the fact that this is our front line, and you've said it yourselves, that this is the most critical area. And we've still got people on the front line walking around without the vaccine, and they've got essentially another 3 weeks that they're able to do this.
That's right, and we want to give them every opportunity to be vaccinated.
Why give them? Why not make them?
Well, there's a very good practical reason for this. Because you can't immediately withdraw 10 or 20% of your workforce and still run the facilities. This has been a process we have been going through. A huge number of our workforce have taken up that offer, and our frontline workforce. All the protective measures like testing, infection prevention control and so on remain in place, and we are now working to ensure that those who haven't yet been vaccinated are either vaccinated or they are moved out of frontline roles, and that's a part of the plan.
When the Pfizer vaccine was first approved, he said that any border-facing worker who wanted one would be able to have their first shot by 2 to 3 weeks after the first batch arrived. We're now sort of 6 or 7 weeks in. Is this what you were expecting or thinking of when you made that sort of commitment?
I was expecting, and I believe we met that expectation, that everybody would have had the opportunity to receive that first dose. Some haven't yet taken up that opportunity for a range of reasons. Some will be personal, some will be practical. The aim now is, of course, to make sure that those who haven't yet been vaccinated are vaccinated, and that we continue with the second vaccine for those who have already had their first.
So can you...
The Prime Minister said that we're up to 95% of our vaccine. 95% of the vaccines that we expected to deliver had been in the past period. What is that 100% figure? How is that determined? 95% of what?
Yeah, so the 100% would be what the DHB's plans say they will deliver over a period, and then we aggregate those up to a national delivery number.
And those plans have been, you mentioned that the plans have been revised through to the end of April.
End of
when
April.
were those that they put together originally? So what period did the first batch?
The first plans would have taken us from around the middle of March through to the end of April, and then the plans that we'll be releasing later this week are the plans that DHBs have got to vaccinate all the next groups through to the end of June. So that will give a really clear idea of what each DHB expects to be, the number they expect to be vaccinating and how they expect to go about that.
So can you...
Based on more than just the number of appointments that have been booked for vaccines, they're based on?
Yes, they're based on each district health board's allocation on a population basis of who we would, and on the availability of vaccine that we're expecting from Pfizer between now and the end of June, noting that we have to also keep enough to ensure that everyone can get their second dose through to the end of June as well.
So can you square with us here? What's the issue? Is it the fact that when you were planning and coming up with that 2 to 3 week scenario, was it not taking life into account with people? Was it people saying no when you didn't expect them to? Can you just, what's happening here though? What's the reason that people aren't getting the vaccination?
Well, I'll just go back to the comment I made earlier on. There is a range of reasons, but what I'm satisfied is that everybody working at the border has had the offer to and the opportunity to receive that first vaccine. Many of them have taken up that opportunity. Others have held back for a range of reasons, or they have not been able to do it for logistical or personal reasons, and that is why we are now following up and making sure that all those who haven't yet are vaccinated.
Those
Brigadier,
people,
can
those,
we,
can I just one last one?
Please.
Those people are there people who have refused the vaccine who are still on the front line, or those people who have point blank refused, I'm not going to get it? Have they been moved into other roles?
Those people would be at the head of the queue to be having a conversation with their employer about redeployment, but they won't have been required to be redeployed yet. The end date for that was always envisaged to be the end of April.
And do you have any numbers on sort of how many of that border workforce are point blank refusing?
No, I don't have exact numbers.
But there are still people that have refused the vaccine that are working in frontline MIQs.
At the moment, because there is a process that needs to be gone through, as you can imagine, with an employee, with the unions, and we have worked closely with unions right from this. And as I say, there are 300 different employers. Some of those are private employers, many of them are in fact, and some are public employers. And so that's why we have worked, and Brigadier Bliss and others have worked very closely with those employers to make sure that the process, which is now underway, of shifting those people out of the front line is initiated.
How urgent are these conversations, and what will these conversations entail?
Oh, well, I can't go into the detail. I can't preempt what those conversations will be, but they will involve employer, and of course any union reps that might be involved, and they're starting today.
So is it the union stuff, is that getting in the way?
Not at all. The unions have been engaged and supportive about this right through. It's not a straightforward process, as you can imagine.
Brigadier, can we just let the logistics play out? No, that's okay. Yeah, perfect. Your comments earlier when you talked about the audit, saying that it didn't find anything immediate that you needed to work on. Can you walk me through what's the scenario that your best case scenario or your best working theory on how they caught it from each other? Can you just outline that?
So that's an investigation that's still going on from ARFS in relation to the genomic sequencing. How we're supporting that is with the likes of the CCTV footage to see if there is a discernible link that we can ascertain. Also checking in the who's on location and staff rostering. So we're trying to find where is there a touch point there somewhere where they've both been in the same room, they've both crossed over at a certain time. And to date, we haven't found a link for that at the moment.
But no one's done anything wrong at this point, as per your audit finding.
We can't determine if there's been a staff mistake or anything at the moment. No.
Just on the, sorry, just back to these conversations, Director General. Just as a scenario, there's somebody that's been hesitant to get a vaccine. An official sits down with them and walks them through it. They're still not happy and they're still not getting the vaccine. Is there a scenario where they can still return to work afterwards, or will they be immediately after that conversation where they've implied or said explicitly that they don't want the vaccine, they'll be removed from the front line?
So just to clarify, it won't be an official who sits down with them, it will be their employer. And the employee may or may not have a union or another representative as part of that conversation. Look, it will be, I imagine it will be a series of conversations. It's not, here is the conversation, here is your ultimatum, and either you have the vaccine or don't turn up at work tomorrow. It's a discussion with employees about other options. Some people, when it comes to that point, may well then decide they do want to take up vaccine, and of course that choice and option should be open to them. For some, there will be an option for redeployment. And for others, that option may not be there. So, of course, the process has to be worked through for every individual.
But isn't this a big sort of link in the or weakness in the defence here? That people have to have a number of conversations before they get to a point where they're moved. At the same time, they're walking around MIQ facilities vulnerable to the disease.
They are working in the facilities in the same way they have been working to date, which is very aware of and taking precautions around infection prevention control and doing everything to keep themselves and others safe. And so I don't see that changing. Yes, and that's their choice. And the point here is that it's not a one-off conversation. It will be a series of conversations. And the finish date for those conversations is, as the Prime Minister says, the end of April.
What are some of the reasons for the refusals that you're getting from frontline workers?
Look, I don't know what the reasons are, but I imagine that there is a range of reasons that people have.
Do you have any anti-vaxxers working on the front line? Do you know?
It depends what you mean by anti-vaxxers. There will be some people in our frontline border staff, as there are in every part of society, who have got a very clear belief that they don't want to have the vaccine. However, all our surveys and experience shows us that that's a relatively small proportion of people. For others, they may have specific questions, they may have concerns, and many people do. They want their questions answered about the rapidity with which the vaccine was developed and so on. They will just also want to see how things are going with their colleagues. And these people will have their own personal reasons.
Are you looking to make the testing register compulsory?
Yes.
Yes, thanks. Given the flux of staff in and out of the system, are you able to get to a position where you can require that incoming staff are vaccinated before they work on the front line?
Yes. So the 1st of May becomes a really important date, and it's our expectation that any worker that comes into work in one of our facilities will be vaccinated. And it's been the conversation with employers, both government employers and private sector, over late last week, setting our expectation for that to occur with effect the 1st of May.
So just to be really explicit, does that mean that they will have 1 dose or 2 doses of vaccine before they arrive at work, or that they'll just have an appointment booked?
1st dose.
Right. And are you able to legally require that, or is that just like an informal expectation with the employers so they understand who they can put in those environments and who they can't?
So that's a piece of employment law, and I think the border audit allows us to do the required as a high risk area. So that's what we're working through at the moment with the employers.
Can I ask what sort of the information systems that are being used in these for this portion of the vaccine rollout? You've obviously got a national CIR, it's referred to an acronym, and then there's a MIQ border clinical management software or something like that, which is being used to monitor and track which staffers here have vaccine and don't have vaccine, and who has access to it, and what insight into it do you have?
Absolutely.
So the border worker testing register will be able to include information about vaccine status, and that will be used by employers who will in the future all need to be using the border worker testing register. And that will also show vaccination status.
Right, is that the Valentina software one that's being...
No, it's not. No, that's the information system that's used within the MIQ.
And how does it cross over with the national register, and what can the ministry see of it? Like, are you able to use that software yourself to see who is vaccinated and not?
Well, we have a record of vaccination status in the CIR, the COVID immunisation register, and obviously a subset of those in that, which is the full register for everyone who's been vaccinated. A subset of those are the people who are working at the border. They are also recorded on the border worker testing register, and there is a link across through the NHI National Health Index number.
And does this use of the software and the way it's fragmented, I mean, does that complicate your picture of who's been vaccinated, who hasn't, what staff there are and what aren't, or is that...
Not at all, and it's not that it's fragmented, they are just different systems. The key here is that the NHI number allows the linkage to occur across a range of different information systems, and as we move into the wider immunisation program, that will be the key as well to being able to link across the booking system, recall system and the CIR, and of course for those for whom it's relevant into the border worker testing register.
Can I just...
Brigadier Bliss, I'm just wondering, case B, how frequently were they tested in March?
So we're showing that they weren't tested in the period that is under investigation for infection. Their last test, so their most recent test was the 8th of April, but they weren't tested in the period of investigation.
Why not?
We're still doing an investigation into that and their testing regime.
So when was their last test?
When was the test? It was mid-March, wasn't it? Their last test before the April test? Did I hear that right?
No, I'm saying the period of March through to now, which is the infection period, and that they weren't tested during that period. And we're just now going back and conducting the investigation to their previous testing regime.
So the only time they were tested was when they got this positive case on the 8th of April, or
as part of the surveillance regime, yes.
So isn't that quite a large gaping alarm for you?
It's a concern, yes it is, and that's why we're going back to check their testing regime, and also what we can do to strengthen the process of understanding tests coming into MIQ.
With all due respect, it's not strengthening the process. They weren't tested, so that's the process is failing.
So that's a conversation between the District Health Board, the employer and the employee, which we're working through at the moment to make sure that the data that we receive back is accurate, not only from a overall facility and employer perspective from compliance, but also that the employer and employee are having those conversations to ensure that if they are not picked up in the surveillance testing or having completed it, that there is a check and balance in place to then trigger a question and an action that would result in being tested.
So that's not happening. So if someone's not being tested, you don't know about it. Is that what? Because I mean, it seems like a very simple system that if someone doesn't get tested, that should set up an alarm, and then that should be followed up.
Yeah. So MIQ receives a weekly and soon to be bi-weekly snapshot across each of the facilities of what the staff testing rate is. As I mentioned earlier, 93% for the Grand Millennium. There's a little bit of slippage for that where that's completion of testing, not necessarily result. So test results will affect today 93%. There'll be an additional percentage which will be NHI number matching and also waiting for the test result to come back. So that's a very good completion rate, for example, for the Grand Millennium.
Just to confirm, so do you or do you not know when case B was last tested prior to the infection?
So we're still investigating that at the moment, but we are concerned that it wasn't in accordance with our 14-day testing regime.
How are you still investigating that?
You expect to find that out?
I think we should know that by the end of the week.
If you have this software that monitors who's been tested, when they're getting vaccinated and such, why can't you just go and find out?
So there's access to the information and sharing of information requirements because of privacy. So the border worker testing register is a Ministry of Health register which feeds us with data information testing completion, not necessarily about each individual. Yeah. So that's available and accessible to the employer.
Can you just ask them?
Only the employer.
Can you just ask them when?
Only the employer can obtain that information. Like Dr. Bloomfield, your staff can't go into that system and then provide that information to MB.
Yes, we can, and in this case, that is happening in discussion with the case and their employer, and that is ongoing discussion. Because sometimes there is, as Brigadier Bliss has said, sometimes there is not an NHI match, and so we want to make sure that we can confirm the records of a person about where they're testing, what the employer has got, and in this case, the employer keeps their own record as well as we've got in our what we've got in our border worker testing register, and we want to get that right.
So in this case, there's a bit of patchiness in the information. Is there? Is that what
we're just aligning all the information in discussion with the case and their employer.
So why can't you ask the case when their last test was?
That's of course part of it, and then we need to verify that information by looking at the information the employer has got and the information on our border worker testing register, confirm that the NHIs match. And that is an ongoing discussion.
Can I ask about those India cases from the press release that have come through? So of these 7 new in isolation, 6 of those were from India. Obviously, because they're day 7 tests coming through, how long should we expect that lag of those India cases coming through before that kicks in? Should we expect to see those numbers for the next few weeks?
They will decline over the next few days. First of all, I think, as I said, 3 of those cases were contacts of other cases. So they were found at, I think, one at day 3 and a couple at day 7. The other cases were picked up at day 01 testing. And we were seeing the vast majority of those cases coming in from India were being picked up at that day 01 testing. So the flights stopped from 4 p.m. yesterday. And so I think over the next couple of days, we should start to see those numbers of cases and people who have returned from India decline.
And so the genomic sequencing, which we've had back, so that would imply that there isn't some missing link between A, B, and C somewhere in the chain?
We can't rule it out, but it's the fact that the returnee and cases A and B have got identical genomes. There's no difference in the bases at the points where the differences would be. It suggests that there's a direct line of transmission, and the only difference is a 1 base difference with case C, but there's obviously that very strong epidemiological link when they worked 2 shifts with case B at the time when case B was infectious.
Can I just confirm case C was a cleaner?
No, case A was the cleaner.
Yeah.
Case C is a fellow security person who worked the same overnight shift with case B. So in that sense, he was a close contact.
But isn't the person that was driving case B to work?
It's not that person, right? There's a question to that.
Thanks, Dr. Bloomfield. I realise there's some flux with the border workers, which is why it's hard to get a number on how many haven't been vaccinated. How do you then work out your percentage? How are we getting that figure?
So we worked that out through the denominator we have got. But if we look back at before we started the vaccination program, we had expected, based on the data we had, that would be about 12,000 people. At the moment, as we've rolled out the vaccine and as people have rotated in and out, it's actually nearer 20,000 now. So the denominator has increased a lot. But we know we've got a high proportion of people who have identified as, or we have identified as border workforce, have been tested, have been vaccinated.
And so MIQ workers specifically then, they're a bit more fixed. You said there's 170 staff at the Grand Millennium. Do you know how many MIQ workers have not been vaccinated? How many at the Grand Millennium, for instance?
I don't have that data, sorry.
Yeah, we are still confirming that information, and my hope is when we do a stand-up later this week, we'll have much better data about the exact proportions, including at different facilities.
Can you explain why the infectious period for case B was sort of lengthened beyond what, if they were originally supposed to have been symptomatic on the Sunday, then they would have been infectious from about the Friday, but it's just got back to the previous Monday.
Yes, it's based on two things. One is the fact that the genome sequence is identical to case A, so we're therefore looking to see, well, if there was a direct infection, that would have happened possibly around the 22nd of March, and therefore taken that infectious period back. The other is the results of the serology testing, which seem to suggest the infectious period may have started a wee way before we had originally thought, and that's why we've extended it back to late March.
And you mentioned that Pfizer's been very good at meeting their delivery targets. How far ahead do you usually get notified that a shipment of vaccines is coming? And can you tell us when the next one will come, or is meant to come, and how many vaccines will be on?
Several weeks ahead, and I don't have the data around the forthcoming vaccine shipments over the coming weeks, but we can provide that.
Why did it take so? Go ahead.
On the case, not knowing when case B was last tested, what did they tell you that their last test result was?
They didn't tell me anything. That's a discussion the public health unit has with the person, and then that's been mapped across with what the records of the employer are, and also going back and looking at the border worker testing register, and that process is continuing.
So why is that taking so long? Surely are they not to be trusted? Does the public health unit not believe them? As it was quite unrealistic that it was maybe February or something that they last had a test?
The public health unit is working to triangulate the results between the employer records, what the employee's recollection is, and also what's in the border worker testing register.
Is it quite some time ago that you're trying to get to the bottom of exactly when it was?
What we can say is, we're looking at the period ahead of mid-March. What we can say is we haven't been able to identify a test from the middle of March until the one that was taken and the confirmed positive test on the 8th of April. And that's the period we're focused on, because that's the period relevant to this.
So it's almost a month. Is that good enough?
Well, it was from the middle of March through to the 8th of April. And you've asked Jim Bliss about that, and he said that is a concern.
So, sorry, do you have a date for before the middle of March? I'm just a bit confused by that.
We'll be going back.
Right. And are you confident that the routine testing, whatever the word you want to use for it, surveillance, whatever, the routine testing is occurring as you'd expect at these facilities at the moment?
So just to put in context, the surveillance testing is every 14 days, except if you're in the quarantine facility, it's every 7 days. And so we get the feedback weekly about the testing rate. And I'm confident that the testing is occurring at a high rate for our facilities, acknowledging that there is a little bit of a lag with the NHI numbers and the like. I'll just make a point about data, I suppose. We stood up a program called Who's on Location rapidly at the end of last year and trialled that system. The data from that system has been taken into the border worker testing register and has provided some of the base data. That's required us to do a fairly large cleanse of that data to make sure we don't have ghost workers in relation to someone who may have used the wrong initials, name, or a slip of the fingers on the date of birth and like. And there's been a significant cleanup of that data over the last 2 months once the trial was complete. And so we're waiting on this week the first of the new reports to give us a better indication about the accuracy of our data, which will then allow us to have those discussions with those employers around their accuracy or the staff testing rate for their staff.
So can you, sorry, this new system, I don't believe I've heard of it before, I might be wrong, but what is it? What does it do?
So previously, I mean, remembering that when MIQ started, we were doing things with pieces of paper and pencil, and that was how we were monitoring and keeping account of movement in and out of the facilities. So Who's on Location is a software where you essentially sign into the facility either on an iPad on entry or using an app on your phone. And the process is you sign in, it asks you a series of questions. You put in your name, your date of birth, your cell phone number, your email address, for example, and then you are then located on the facility. You then sign off as you leave the facility, and it records that data that you've been on that facility. What that does now is that now sends, that data has then been used for to populate the border worker testing regime. We're now going through, as I said, scrubbing that data to make sure we're correctly matched with what we've got on those two registers.
So you compare it, basically.
Yeah, so one is fed the other, and we can now go through and make sure that they are accurate. So there's not a J Bliss and a Jim Bliss, for example.
Yeah, Dr. Bloomfield, just one call for a colleague.
Jason, so you have confidence though that you are getting the required amount of testing happening?
Yes, so that's leading to greater understanding of the testing rates.
But currently, do you have that confidence, or do you not have that confidence, which is why you're doing this?
This is why we're doing the investigation, is to go back and you've gone from testing or examining bulk data in percentages to now having the ability to go back and interrogate data around specific individuals.
So as it stands at this moment, you're not confident that the required testing is occurring?
I think we've got a system to put in very rapidly. We've made great improvements in it, and I think the next things we're doing to increase that understanding will give us that assurance that it is as best as we can make it.
Dr. Bloomfield, just one more from a colleague. Why did it take so long for the ministry to release the locations of interest in relation to the security guide?
Because we released it as soon as that information was verified. There were a number of follow-up discussions between regional public health staff and the individual, and also a look back at FPOS and other records to verify both the locations and the time that the person was there. So the final question there.
Yeah, just a question about the Janssen vaccine. Let's say I understand it's meeting tomorrow. If it's approved, what are our plans for it?
So if it's approved, there's still another, through MedSafe's process, there's still a requirement that this vaccine would require approval by the Environmental Protection Authority. So that process will need to go through. We also know from our discussions with Janssen that the vaccine would be available from sometime in Q3 onwards. But there is also a process, a decision that Cabinet needs to make about decision to use that vaccine, and that would be based on advice around for whom and in what circumstances and when we would use that vaccine.
Do we need it?
Well, we are still keen to ensure we've got at least one backup vaccine to protect against any risk that may not have been realised yet around supply of Pfizer. Things are looking good there, so that's important. But also we know that there is a group, particularly those under 16, for whom we want to vaccinate, and we're not sure which vaccine may well get the evidence first that is safe and effective, and so having a backup is helpful.
I asked about influenza really quickly, kind of off subject, sorry, but the influenza vaccine, there seems to be delays in it arriving in New Zealand, and it might be that any vaccination campaigns occur mid-June, or into the winter and the flu season. What's your feeling on this? What do you know about it? What's your concerns?
So I don't have any concerns. The flu vaccination program starts this Wednesday with a vaccine that is specific for over 65s. Then the vaccine that can be used more widely for under 65s with anybody, but in particular we're interested in those with pre-existing conditions, arrives in mid-May, and general practice is aware of this, as is pharmacy, and they are geared up to go from this Wednesday with that first group, and then from mid-May with the wider population.
So for that more vulnerable population, it's okay. What about more broadly? I mean, a lot of companies, about the vaccine to their staff. That seems to be pushed further down into the year.
So to be really clear, our priority for vaccination this year is COVID-19, and I think employers, private and public, understand and agree with that as a priority, and that's where we'll be focusing our efforts. And if there has to be a trade-off, we will focus very much on the COVID-19 vaccination. Thanks very much.